Hello everyone, I hope everybody's doing well. This is Mr. Cash and we are still on chapter 11, ventilation, and I am going to continue from surface tension forces. And if I make a mistake, please forgive me, and I hope you learn from this lesson. So surface tension forces. So part of the hysteresis is difference between inspiration and expiratory pressure volume curves exhibited by the lung is a result of surface tension. So surface tension, forces in the alveoli. So what is the surface tension? Surface tension is the molecules on top of the surface that contract together. So the alveoli, so let's say this is the alveoli, and it has like a thin coat of liquid right here. And right here on top of these liquids, there's tension of water, which is liquid of molecules. This is surface tension. Surface tension is the molecules that are on a surface of the liquid that are together, that creates a barrier, a tension. So if you kind of look at insects or like mosquitoes or little flies, when they're on top of the water, they are actually sitting on surface tension. So here, since the alveoli has this thin liquid, it has surface tension here, right here on the barrier. So that tension has some effects on the lung. So we're gonna keep reading. If a lung is filled with fluid such as saline, the pressure volume curves look much different than the pressure volume curves of air-filled lungs. So they're talking about this figure here. Less pressure is needed to inflate a fluid-filled lung to give a volume. So here they said you need less pressure is needed to inflate fluid-filled lung to give volume. The phenomenon indicates that a gas-fluid interface in the air-filled lung comes its inflation-deflation characteristics. So what they're saying, you need less pressure, and you need that less pressure to inflate that lung even though it's filled with fluid. You would think that you need more pressure, but you actually need less pressure because of surface tension. Surface tension creates that exhalation force, so that way it collapses quicker. So you need actually less pressure to inflate that lung. The recoil of lung is a combination of tissue elasticity and the surface tension forces in the alveoli. So here you go. This is the first sentence that tells you that surface tension and the tissue elasticity. So elasticity is anything that can expand and it goes back to its original form, which is like a spring. If you have a spring, they showed here in the second slide a bunch of springs. This is elasticity. So the lung has that elasticity forces, which when you inflate it with volume, with air, it has a tendency to go back to its original shape. So surface tension and elasticity, they have that tension force in the alveoli. During inflation, when you inflate that lung, additional pressure is needed to overcome surface tension forces. So you need more pressure to overcome that surface tension, because remember, the surface tension is on the alveoli right here outside and is all pulling. These forces are pulling this way, that way, and that way, and then that one is pulling this way, and those right here is pulling that way. So they're pushing to try to actually collapse the lung, which closes the alveoli. This is what surface tension is doing right here. So it needs a higher pressure to push to overcome this surface tension here, or inside the alveoli. Okay. During deflation, surface tension forces are reduced, resulting in altered pressure volume characteristics. The leftward shift seen in figure 13. In the intact lung within the chest, the volume history also affects the degree of hysteresis that occurs. Factors such as initial volume, the tidal exertion, and whether the lungs have been previously inflated or deflated help to determine the volume history and shape of the pressure volume curve of the lung. Mini clinic. Those mini clinic in this book is really helpful because they give you a case and they give you the discussion at the bottom here, right? So let's talk about, so this mini clinic talks about, okay, let me just continue with the reading here and then we'll go back to this mini clinic. The mechanism of action of pulmonary surfactant molecule is based on its weak intermolecular attraction forces. So they say, okay, now they have a mechanism action of pulmonary surfactant molecule. So surfactant is produced in the lung, which is a chemical that is in the lung, is based on its weak intermolecular attraction forces. When surfactant molecules are mixed with other liquid molecules that have higher intermolecular attraction, the surface molecules are pushed to the surface of the liquid, where they form the air-liquid interface. Because of the weak intermolecular attractions between the surface molecules, surfactant molecules and the surface, the liquid lining of the alveoli, here we go, they're talking about the liquid lining of the alveoli exhibits much less surface tension with an absence of pulmonary surfactant. So they're saying that because surfactant, remember I said this is the alveoli, then you have that thin coat of liquid, and we said we have surface tension, right? Right over here on the outside, the surface of that, this is the alveoli. Okay, so that surface tension here is pushing this way, is trying to collapse the alveoli, right? In all directions, right? Now we have surfactant, right, which is produced by one of the cells that is in the alveoli, and the job of surfactant is to decrease surface tension, to lower surface tension, so that way the lung doesn't collapse or it doesn't give it that recoil, right? So it actually regulates surface tension that is around here, okay? So what they're saying here, that they said that if it's mixed with other liquid, it will make surfactant less workable, it will be less effective, okay? Let's continue. In a premature infant with inadequate surfactant, the intramolecular surface tension is abnormally high. This produces a collapsing of force, increasing lung recoil, reduces lung compliance. There we go. So what they're saying here is when you have in a premature infant is any infant that is born before 38 weeks. So any premature infant that was born before its due date, that means a baby that is a woman who gave birth to a baby that delivered a baby that is like 8 months old or 7 or 6 or even 5 or even less than that. So that's called premature. So they're saying here, in a premature infant with inadequate surfactant, so since the baby was born before its due date, it doesn't have enough surfactant, right? And we said surfactant regulates to help with surface tension, right? So it says here the intra-alveolar surface tension is abnormally high. So that means the surface tension that is here, it's very high. So that means it wants to really collapse that alveoli, right? Because you don't have surfactants to regulate surface tension here, right? Now, this produces a collapsing, remember, if the alveoli wants to collapse because there's not enough surfactant, right? Forces to increase lung recoil. Remember, I told you about recoil and elasticity. So now, the surface tension, since the baby doesn't have enough surfactant, it wants to collapse because there's no surfactant to regulate surface tension, okay? Greater muscle, okay, we're up to here, okay. So now, forces that increases lung recoil and reduces lung compliance. So the lung is not compliant, it doesn't want to expand. It's very hard for it to expand, okay? Greater muscular effort is required to overcome increased recoil during inspiration, and the work of breathing is increased. The infant may eventually become fatigued and develop ventilatory failure. Inhalation of artificial surfactant into the lungs reduces surface tension to its normal level. Lung compliance is increased, elastic recoil is reduced, and the muscular work required to inflate the lung is reduced. So this sentence from here where it says great all the way up to here, what they're trying to tell you is, since we had this premature infant was born with inadequate surfactant, which means doesn't have the right amount of surfactant in their lung, the lung wants to collapse, right? The lung wants to collapse, wants to recoil. It's very hard to inflate it, very hard to open the lung. So when you inhale, it's very hard for the baby to inflate it. Kind of like if you have a balloon, is trying to blow into it, but it's so hard. So it's difficult for you to blow into that balloon, right? What the infant is trying to do is to open that lung, but it's hard because of surface tension that is attempting to collapse the alveoli, right? So what they do with these infants is they give them inhalation artificial surfactant, where they have surfactant manufactured, right? So they give them surfactant because it's a hormone. So they give them surfactant into their lung. And what it does is, remember, now you have enough surfactant, and surfactant, their job is what? To reduce the surface tension in this coating right here. So once surface tension is normal, it's reduced because you already gave this infant artificial surfactant. Lung compliance will increase. That means the lung will become more compliant. You can inflate it because surface tension is reduced. Once the baby can inhale and compliance is increased, elastic recoil is reduced. For the lungs to recoil and collapse is reduced because we already reduced surface tension with the artificial surfactant. Now muscle work required is less, so the baby won't have to breathe as hard or as much, so that way they can inflate that lung. So the work of breathing goes down, the baby looks fine, he can inflate his lung easily. And remember, it comes to a point sometimes where they're breathing so hard they will have to be intubated, because remember, if they breathe too much, eventually they're gonna get tired. When they're tired, respiratory failure will happen and they can't breathe. So therefore there's no more air going to the lungs, no more oxygen. Oxygen is deprived. That's it. The baby will die if you keep them the same way. They will fail, and eventually they will go into cardiac arrest if intervention is not given at the right time. That means if the baby is not intubated and mechanically ventilated by a vent, the baby can die. So they have to work really quick to give them artificial surfactant. Also depends on the infant, how the infant is doing. If they have heart problems, and other things can factor to it. So they really have to be very careful with infants. So surface tension is really important to understand it, because that's where you're gonna shine, is with the infants. So if you know what you're talking about, it's really nice to understand it. Now we're gonna move on to elastic forces opposing lung inflation. Elastin and collagen fibers are found in the lung parenchyma. Parenchyma is just the lung, the tissue of the lung. Sometimes I go in detail in these videos, and I do it for a reason, because I have some of the students, they tell me, can you please break it down and go into detail, because there are students that is hard and difficult for them to understand, and it's even hard for me to understand sometimes, and I'm already a practiced respiratory therapist. So forgive me if I take too long in these videos. There's no other way around it. If you want to understand the concept and be a good therapist, you have to really study and understand this material. So let me continue. Elastic forces opposing lung inflation. So now they're going to break down the elastic forces, any elastic force that is opposing lung inflation. That means the lung wants to inflate. The tendency of the lung, when you breathe in, it wants to open up, right? But there's elastic recoiling that wants to close it. That's right here, like the springs. If you try to open the spring, but there is a recoil force that is trying to go back. Elastin and collagen fibers are found in the lung parenchyma. So what causes some of these elastic forces to be collapsed is elastin and collagen fibers. And these fibers are found on the lung, which is the lung tissue. Any lung tissue, it has elastin and collagen fibers. These tissues give the lung property of elasticity. So this is what gives elasticity to the lung. Those two fibers, elastin and collagen. And collagen. So you might get a question like that in a test. You know, that's a good question to ask anyway. Okay, these tissues give the lung property elasticity. So elasticity, okay, now they're gonna define elasticity, is the physical tendency of an object to return to initial state after deformation. So what this means is elasticity is anything that wants to go back to its original shape. So if you, right here, a good example, if you have this spring right here and you pull on that spring, elasticity is the tendency for it to go back to its normal shape. So the lung is the same thing. When you inflate the lung, because it has elasticity, remember the parenchyma, the lung tissue itself, it has elastin and collagen. When you inflate the lung, the tendency of it wants to go back to normal because of elasticity. Okay. When stretched, an elastic body tends to return to its original shape. The tension developed when an elastic structure is stretched is proportional to the degree of formation produced. Hooke's law. And then they talk about this law here. An example is a simple spring. There you go. They're talking about this recoiling spring here. When tension on a spring is increased, the spring lengthens, it becomes longer. However, the ability of the spring to stretch is limited. It's true, it has a limit. Same thing that like the lung, if you inflate it, if you overinflate it, if you give it a lot of pressure, it will eventually pop. The lung will pop, and then you can cause pneumothorax and so on. So same thing here with this recoil. What they're saying is if you over pull this spring, if you pull it too much, you can break it. So same thing like the lung. When tension on a spring is increased, the spring lengthens, okay? When the point of maximal strength is reached, further tension provides little or no increase in length. That means it will not do anything to it. Additional tension may break the spring. There you go. Additional tension may break the spring. And remember, a lot of pressure given using that ventilator, you can cause pneumothorax. because of we gave it too much pressure. You pop the lung. Now air escapes between the pleural space, in the pleural space, and then that causes pneumothorax, and that air right there escapes, collapses the lung more. And that can be, if it's tension pneumothorax, that's a life-threatening condition where you have to really get immediate attention by the healthcare providers. In the respiratory system, inflation stretches tissue. The elastic properties of the lung and chest wall opposes inflation. So you see now, what opposes the inflation when you inflate the lung is two things: the lung elasticity, surface tension, lung elasticity. Now they put in chest wall. Also, the chest wall has elasticity fibers. Remember, your lung is here, your chest wall is here, right? And you have right here what I'm creating here between. This is, let's pretend it's the pleural space. This is your chest. Your chest has ribs, right? When you inflate the lung inflates, the ribs go like this, and then it wants to go back because the ribs want to naturally go back. So that force right there is the tension that opposes inflation. To increase lung volume, pressure must be applied. So to increase the volume that you're giving the patient, pressure must be applied. The property may be shown by subjecting an existing lung to change the transpulmonary pressure and measuring the associated lungs and the volume. To simulate the pressure during breathing, the lung is placed in an airtight jar. The force to inflate the lung is provided by a pump that varies the pressure around the lung inside the jar, stimulating pleural pressure. This action mimics the pleural pressure changes associated with the thoracic expansion and contraction. Okay, so this is what I just explained. The changes in transpulmonary pressure are made in discrete steps, allowing the lungs to come to rest in between so that all of the applied pressure opposes elastic forces and more it opposes resistive forces. Flow is zero when the measurements are made. So those are the pressures that I explained earlier in this chapter. The amount of stretch inflation is measured as volume by spirometer. Changes in volume resulting from change in transpulmonary pressure are plotted on a graph. Okay. So here they're talking about this jar here. So they did the same thing. You have pressure, but I won't use a jar because this is the lung, right? The jar is, it has to have the ribs. It has to have the ribs, so that way you'll know that they create, like they said it in the paragraph, but you cannot imagine it if you don't have ribs, right? Because remember, the ribs tend to go this way, they pull that way, and this goes that way, then the rib goes this way, and so on. Okay, so when these ribs flare like this, when you breathe, they go like this. And when they have a tendency, they want to go back to normal, so they create a force, which is that force transfers and it goes into the lung. And then remember, the alveoli with surface tension, elasticity on the lung, that creates another pressure. So this forces wants to collapse the lung. That's why inhalation is active, exhalation is passive, because of the recoil of the lung, diaphragm, and also the chest wall, and the pressure changes between the atmosphere and inside your lung. During inspiration in this mode, increasingly greater negative pleural pressure are required to stretch the lung to a larger volume. As the lung is stretched to its maximum, which is total lung capacity, the inflation curve becomes flat. This inflating introduces increase opposing to expansion. For the same change in transpulmonary pressure, there is less change in volume. Okay, let's just keep reading. This paragraph is, I already explained most of it right here. So, but still read it, understand it, try to understand it, and please forgive me if I missed anything or I misled you of anything, but I try to do my best in these videos. As we spring with tension is removed, deflation occurs passively as pressure in the jar is allowed to return toward atmospheric pressure. This is what I said about atmospheric. Okay, deflation of the lung does not follow the inflation curve exactly. During inflation, lung volume at any given pressure is slightly greater than it is during inflation. This, if you want me to do another video on the pressures and trying to explain it a little more better, please let me know in the comments below. Also, share this video with your classmates or whoever you think can benefit from it, because this can help. So I understand that there's people out there that wants to learn. Okay, this differences between inflation and deflation curve is called hysteresis. Hysteresis indicates the forces other than simple elastic tissue forces are present. The major factor, particularly in sick lungs, it is the opening of collapsed alveoli during inspiration that tend to stay open during exhalation until very low volumes are reached. Okay. Let me go back so we can do that mini clinic. Okay, let's read this. Surfactant replacement therapy and lung mechanism. If an infant is born prematurely, the lung may be unable to produce adequate amount of pulmonary surfactant. We already said that, so we already know that. How does this condition affect lung mechanism, and what effect does surfactant replacement therapy have on lung compliance in the work of breathing? Okay, discussion. The liquid molecules that line each alveolus attract one another. This attraction creates a force called surface tension, which tends to shrink the alveoli, makes the alveoli smaller. That's when we say lung collapse. Okay? Which tends to shrink the phospholipid called pulmonary surfactant. So it's a lipid. It's a phospholipid, which called surfactant. So this is a test question. Reduces surface tension in the lung. Alveolar type 2 cells produces pulmonary surfactant. So the cells number 2 that are here, those are the ones that produce surfactant. This is another test question where they ask, what produces lung surfactant? Which type of cell? This is a question that I countered many times in many tests, and it's type 2 cells. So you have to remember that type 2 cells produces surfactant. And in contrast to typical surface activity ignites, pulmonary surfactant changes surface tension according to its area. This ability of pulmonary surfactant to reduce surface tension decreases as surface tension area volume increases. Conversely, when surface area decreases, the ability of pulmonary surfactant is reduced. Surface tension increases. This property of changing surface tension to match lung volume helps stabilize the alveoli. Any disorder that alerts or destroys pulmonary surfactant can cause significant changes in the work of distending the lung, which means inflating the lung. We already went over that. We said that infants who are born prematurely normally don't have an adequate surfactant level, so therefore given surfactant by a healthcare provider, and then it helps them to regulate their surface tension in the lung, and then their compliance become compliant mean opening the lung is more compliant. It's not doesn't want to collapse. So when it's more compliant, that means you can put air in. When you put more in, you have more oxygen. Patient oxygenate well, they breathe better, and then they get well. So let's move on. So the next one they're gonna talk about compliance. We already discussed compliance, and I'm sure now by now you understand compliance. And then they have much description here. Let's see what else. Rule of thumb. And then they go into resistance. And that's pretty much it. So let me read compliance, saying anything that I can add. But basically, that's it, what we discussed already. Compliance, the reciprocal of elastance. So the opposite of elastance is compliance. Because remember, elastance wants to go back, compliance wants to open it up, okay? So it is the opposite, that's what they're saying. Is caused by tissue elastin forces and forces that opposes lung inflation. Compliance is defined as the constant of proportionality between volume and pressure. Okay, volume over pressure. That's compliance. The opposed lung inflation, okay, an elastic system, and is usually expressed in units of ml per centimeters of water. Ml per centimeter of water. To calculate lung compliance, change to respiratory is substitute for pressure. To calculate respiratory system compliance, used to calculate chest wall compliance. Oh, okay, they already have it here. So compliance is what? Volume over pressure, and is measured what? ml per centimeters of water. So ml is going to be the volume, is going to be in ml. Pressure is going to be always in centimeters of water. Units are very, very important to understand, and to help you in respiratory. You go a long way. Even in when you document, when you put your notes, you document in a computer, always use your units. They are very important. So compliance is what? Volume over pressure. Okay, and that's what's gonna give you your lung compliance. Also, calculation questions on tests always gonna be that way. And always remember, volume, always remember it's ml or liters. Pressure is always gonna be centimeters of water, okay? Especially when you talk about vents and stuff like that, when we get to mechanical ventilation. A graph of change in the lung volume versus change in transpulmonary pressure is called compliance curve of the lungs. Compares a normal lung compliance curve with curves that might be observed in patients who have emphysema. Okay. Obstructive lung disease, or pulmonary fibrosis, restrictive lung disease. So remember, obstructive and restrictive, those are very important words. The curve from a patient with emphysema is steeper and displaced to the left. The shape in the opposite of the curve represents lung changes in volume for small pressures. Increased compliance. Increased compliance results primarily from loss of fibers, which occurs in emphysema. So now, in emphysema patients, they have lost elastic fibers. Remember, we said the elasticity on the lung parenchyma. So because of this disease, emphysema, what happens is to the alveoli, this is the alveoli, and the tissue that is right here, elasticity is lost. It's not elastic anymore. It doesn't want to tend to go back. So the alveoli looks more like this now. So now it's more compliant because of what? Because there's no elasticity, no forces that wants to bring it. Because elastic is, there's no forces that wants to pull it back. So you can fill it up easy. It's more compliant. But restrictive diseases like cystic fibrosis, which has tissue damage right here, so it's very stiff. The alveoli is not like this, it's a normal alveoli, but it has tissue damage right here, which makes it very stiff. The scarring has become stiff, so it's not compliant. It's very hard to inflate it, so you need more pressure to inflate it. Okay. The lung become more disabled so that normal transpulmonary pressures are in large volumes. Then the term hyperinflation is used to describe abnormal increased lung volume. This is what I was just saying, that in emphysema patients it's easy to inflate. They have high compliance. A distinctly opposite pattern is seen in pulmonary fibrosis. I just mentioned it. Interstitial fibrosis is characterized by an increased connective tissue. Remember this, it's tissue scarring, so it increases the connective tissue. The compliance curve of a patient with pulmonary fibrosis is flattened than the normal curve, shifted down and then the right. As a result, there is a smaller volume changes for given pressure. Decreased compliance. Consequently, the lung becomes stiffer, usually with a reduced volume. So remember, in obstructive diseases, obstructive right here, lung disease, you're gonna have increased compliance. So I'm gonna put an arrow for increased lung compliance, okay? In restrictive diseases, right here, restrictive, I'm gonna put an arrow down. Low compliance, that means it's hard because of the fibers is stiff, okay? Can you, okay. Inflation and deflation of lung occur when changes in dimensions of the chest wall. Relationship between the lungs and the chest wall can be illustrated by plotting their relaxation pressure curves separately and combined. Also the chest, okay? In the intact thorax, the lung and the chest wall recoil against each other. The point at which the opposite forces balance determines the resting volume of lungs, or functional residual capacity. So here they just demonstrate, if you want to read these charts, you can. These here just demonstrate lung volumes and normal and now. Okay, so I'll go over this one so that way you'll understand. So this is fibrosis, this is emphysema, and this is normal, okay? So let's take for 3 liters, right? So to fill the lung 3 liters of volume, you only need about, I'll say this is, okay, so if we go 1, 2, 3, okay, so go by 6. So you need about 6 centimeters of water. So this is pressure. Remember I was telling you pressure is very important to understand. Centimeters of water, and you have lung volume. Okay, liters. It's measured liters, but most of the time milliliters, okay? But it's milliliters or liters, same thing, okay? It's just ml is 1,000. So if you have 1 liter, you can say it's, let's say you have 1.2 liters. That's 1 liter, 0.200 ml, okay? Okay, now, this is how much it's gonna take to inflate an emphysema patient. It's gonna take him 6 centimeters of water. But to fill a normal lung, 3 liters, you need right here, which is goes all the way down to here, you need about 12 centimeters of water. But fibrosis patients, and if you go across, it's gonna hit maybe not even, it's gonna hit right here. You need at least 30 centimeters of water. So therefore, you need more pressure to inflate tissue restrictive diseases like fibrosis. Because here the tissue is damaged, you have more compliance and there is no fibers. Remember, he's here, you have scar tissue with that fibrosis. So the lung is stiff. So to deliver a 300 volume, you need a greater pressure to inflate it. But so this is all it means. So always remember, compliance is volume over pressure. Okay, so that's just basically explain this one here. Very simple, you'll understand. Okay, let's continue and see what they still have here on compliance. I just don't want to make this video too long for you because it takes a long time. This is also the point in which alveolar pressure equals atmospheric pressure. Normal functional residual capacity is approximately 40% of the total lung capacity. Okay, so have that in mind, that 40% is functional residual capacity of your total lung capacity. So of the total volume that can go into your lungs, 40% of it is functional residual capacity of them. Okay, the opposing forces between the chest wall and lungs are partially responsible for subatmospheric pressure in the intral plate disease that alter upon chest wall or lung, often disrupt the balance and usually okay. Combined compliance. So combined compliance, they're gonna combine what? Which compliance? Compliance of the lung and the chest wall. The two lungs have their own usual different compliances. Why is that? You know why? Because each lung is separate from the other lung. Okay, so some people might think the lungs are together. They're not together. Each one of them is separate and it's on its own. Okay, however, the muscles or ventilators see a combined compliance because the lungs have the same driving pressure but different flows. They are said to be connected in parallel. Para-compliance combined by simple addition. So para-compliance, total compliance, right and left, and gives you both lung compliance. So there's no need to read the rest. This here is just calculations, so I'll just read rule of the thumb. It's important to read rule of the thumb. Rule of thumb: the lung and chest wall each have their own compliance or distensibility. Means the lung and the chest wall has its own compliance, means to inflate. In healthy adults, the compliance of lungs and chest wall are each equal to approximately 2 liters per centimeter of water. Okay, so 200 ml to fill, it needs to fill the lung 200 ml of water. In a normal healthy adult, you only need 1 centimeter of water. That could be a test question, okay? That's a healthy adult. However, because the lungs are contained within the thorax, the two systems act as springs pulling against driving force. This reduces compliance of the system to approximately half that of the individual components of 1 per H2O. So now, since they have, the chest wall has the tendency to go back, to recoil back, and the lung has that tendency, it reduces it to 1 liter per centimeter. So you will only have 100 ml per 1 centimeter of water. So this is how much, so reduced it by 1/2, okay? Particularly for mechanical ventilation of the lung. Okay, this rule has many particular implications, particularly for mechanical ventilation of the lung. Compliance of the chest wall, similar to lung compliance, is measured of distensibility. Any disease process that alters the compliance of the lung or chest wall can seriously disturb the normal mechanism of ventilation. Obesity. Remember, obese patients will have really hard time to put in volume into their lung because that fat tissue is pressing on their chest, so it's very hard for them to inflate the lung. Okay, that's why obese patients will tend to breathe harder than non-obese patients. Any disease, okay, or any disease that, you know, obesity, sclerosis, any deformity to your spine that makes you bend over like in a gesture, ankylosing spine, okay, many other problems, diabetes, chest wall. So any other diseases, this one. All right. So now the next one from here in on is going to talk about, okay, inhalation occurs when the balance between the lungs and chest wall shifts. Energy from the respiratory muscles, primarily the diaphragm, overcomes the contractile force of the lung at the beginning of the breath. The tendency of the chest wall to expand facilitates expansion. When lung volume nears 70% of total lung capacity, the chest wall reaches its normal resting level to inspire to a lung volume greater than approximately 70% of total lung capacity. For exhalation, potential energy stored in the stretched lung chest wall at high volumes proceeding. Okay. This is all talks about same thing, all about lung compliance. Now let's move on and see what you got here. Helium and oxygen for large area obstruction. Talks about resistive forces opposing lung inflation. So I'm gonna stop here. The video is already long enough, 45 minutes, and then we can continue inshallah with the next video later. We already stopped at resistive forces opposing lung inflation. We already went over compliance, we went over surface tension with the alveoli. That sounds okay. All right, thank you so much for watching. Please do your thing, comment, share, whatever you have to do, so I can see that to motivate me to do more videos. And I hope you learned from this video. And again, please forgive me if I made a mistake, and if I did and you can point it out, please put a comment below so people can benefit from this. And thank you so much.